अस्सलाम वालेकुम। मेरा नाम डॉक्टर मिशी भट्टी है। वेलकम टू माय यूट्यूब चैनल ENT Made Easy by Dr. Mishi Bhatti. Today we have another video regarding the ear examination, and it is the part 2 of the ear examination, where I will explain how to do otoscopy during short and long cases. For otoscopy, the first thing what you need to consider is whenever you are doing otoscopy, use advocate size, basically the otoscope speculum, so that you may examine tympanic membrane very well. Otherwise, if you will use the speculum with a short diameter and with the less diameter, you may have to rotate your speculum to visualize the whole of the tympanic membrane, and in that case you may hurt your patient. So I will start doing otoscopy, and again the rule for the examination is greet your patient, consent your patient, and we both should lie at the same level. One thing what you need to consider is whenever you are doing otoscopy, you should know the rule that you have to hold it in the ipsilateral hand and always hold it like a pen. As you can see now that I am holding the otoscope in between my index and thumb finger, while my rest of the fingers will rest on either cheekbone or the temporal area. So this is my patient, and I'm going to examine his right ear, so that I'm using otoscope in my right hand. As you can see, turn on light first, and now you can see that I have hold it between index and the thumb. Then with the left hand I'm basically rotating the pinna upward, backward and laterally, so that the canal becomes straightened and otoscope speculum insert very well and smoothly. Now you can see that I have rest my other fingers on temporal area of the patient or the cheek area of the patient face. This is how you have to do the otoscopy. Otoscopy should be done on both ears at the same time, and you should change the speculum for the another ear, especially whenever you are examining the infected air. Otherwise, you can also use split swabs in your exam to basically disinfect the speculum at the time of examination. On otoscopic examination, as you know that you will visualize the tympanic membrane, and for tympanic membrane examination, the first thing you need to consider it's basically the color of the tympanic membrane. And normally tympanic membrane is pearly white in color, and when it is infected, as you know that in case of acute otitis media, it is bright red in color, reddish in color, as it's inflamed. Then you know, as in case of otitis media with effusion, tympanic membrane is dull, lustrous and umber colored due to the fluid present in the middle ear. Then in case of the chronic suppurative otitis media, you may not find the normal color of the tympanic membrane. Rather, in case of the healed tympanic membrane, you may find the white chalky deposits or the plaque, that is the tympanosclerosis. Then in case of the retraction, you may find the dull lustrous tympanic membrane. So then after the color of the tympanic membrane, you can comment over the position of the tympanic membrane. Normal tympanic membrane is slightly convex, and in case of inflammation, or in case of any fluid or mass in the middle ear, tympanic membrane may be pushed outward, that is the bulging of the tympanic membrane. And in case of eustachian tube dysfunction or any other cause, tympanic membrane may move onward, inward, that is the retraction of the tympanic membrane. So after the position of the tympanic membrane, you have to comment over the tympanic membrane that it is intact tympanic membrane or perforated tympanic membrane or healed tympanic membrane. First video is regarding the intact tympanic membrane. In intact tympanic membrane, when you are examining the tympanic membrane, first the thing you have to consider is basically the annulus. Can you see annulus or not? Then you will comment over the cone of the light, and in case of the right ear, the cone of light is present at the 3 to 5 o'clock. In case of left ear, it is 5 to 7 o'clock. So you have to comment over the cone of the light. Is it present or absent? Is it at the normal location or it is displaced? After cone of the light, you will comment over the pars tensa and pars flaccida. In pars tensa, you can comment on the normal landmarks what you usually see on otoscopy. That is the horizontal process of the malleus and the handle of the malleus. Sometimes you may also see that the pars tensa is so thin that the incus shadow is also visualized, and sometimes even the promontory shadow also can be seen through the thin pars tensa during otoscopic examination. After pars tensa, you will go to the pars flaccida, and as we know that the pars flaccida is the upper part of the tympanic membrane, and it has got two malleolar folds, anterior and posterior malleolar folds. So for pars flaccida, you can comment over the pars flaccida malleolar folds, and you can also tell about that is it basically inflamed or inward moved, like retracted, and if you find any finding over it, or over the color change, and anything you may find during otoscopic examination, you can also comment about it. Next thing, what you have to look for in case of intact tympanic membrane is mobility of the tympanic membrane. For that, you have to do the Valsalva maneuver so that you may assess the mobility of the tympanic membrane. Always keep it in mind, in case of atrophic and healed tympanic membrane, never try to attempt Valsalva maneuver or check mobility, as it may lead to the perforated eardrum. So for mobility, you have to counsel your patient how to do the Valsalva maneuver. Then you will check doing otoscopy, and while patient has to do the Valsalva maneuver. Now I will do basically the otoscopy, and I will check mobility of the tympanic membrane. अच्छा देखिए, आपने क्या करना है, नाक बंद करके ऐसे मुंह में हवा भरनी है, करके दिखाइए मुझे। अच्छा छोड़ दें, जब मैं कहूँ तब आपने करना है, ठीक है। चलें, अब कीजिएगा प्लीज। Fine, thank you. So you should know that for mobility, how you are going to comment. So in case of mobility, if you have got eustachian tube dysfunction and the retracted tympanic membrane, or any fluid collection in the middle ear, tympanic membrane may be hypomobile. Then in case of atrophic or scarred tympanic membrane, let's suppose if you do it unintentionally or accidentally, then that may be the hypermobile. So you have to comment over the mobility of the tympanic membrane in case of the normal tympanic membrane while doing otoscope. Basically, perforated tympanic membrane, you should know what are the different points you need to consider during otoscopy. So first thing you need to consider is if the tympanic membrane is perforated, is it a single perforation or multiple perforation? Then you have to comment over the shape of the perforation. Like in case of traumatic perforation, you may find a linear shape and irregular shape tympanic membrane perforation. And in case of CSOM, you may find a round, spherical, and a kidney bean shaped perforation. After shape of the perforation, you have to comment over the size of the perforation. Is it medium size perforation, or small size, or large size? When it involves less than 2 quadrant, it is a small perforation. When it is involving 2 quadrant, it is medium, and when it is involving more than 2 quadrants, it is the large perforation. Then you have to comment the quadrants that has been involved during perforation, like anterior superior, anterior inferior, or posterior superior, or posterior inferior. Then you have to tell exactly the site of the perforation, is it located at the pars tensa or the pars flaccida. After this, you will comment over the margins of the perforation. Like, let's suppose a perforation, usually, in case of the CSOM, has got squamous lining and healed margins, while in case of traumatic perforation or the barotraumas, you may have the tympanic membrane heaped outward or inward. After the margins, you have to comment over the rest of the tympanic membrane. Like, rest of the tympanic membrane is normal, congested, inflamed, and retracted, or it has got any tympanosclerotic patch. After rest of the tympanic membrane, you will also comment about the annulus. Is it visualized or not visualized? After this, you can also see the middle ear mucosa from the perforation, especially in case of the central perforation, which is the perforation of the pars tensa, or as you know that the perforation of the pars flaccida is the attic perforation. So usually you can visualize the middle ear through the pars tensa perforation, central perforations. And if you are looking for the middle ear, these are the following points what you will consider. The number one is the mucosa of the middle ear. Is it inflamed? Is it edematous? And it is normal and the dry air. And if you can see the air discharge in the middle ear, you can also ask your patient to do the Valsalva maneuver, as the result of which the air discharge from the middle ear may also come out, and you can also comment over the content of the middle ear, that was the air discharge. So for air discharge, you have to always tell about the color of the air discharge, amount, is it profuse or scanty, it is dry or like debris, and it is the liquid in nature. Then you have to tell it is mucoid, mucopurulent or purulent, and is it fall smell or non-fall smell, does it have any blood tinge association or not. After the air discharge, sometimes you can also visualize the air ossicles from the middle ear across the perforation, and you have to comment about it if you can see any ossicles or not. So these are the points basically you have to consider while doing otoscopy in case of perforated tympanic membrane. Thank you.